Welcome, everyone. I'm Rachel Patzer. I'm the president and CEO of Regenstrief Institute. And I wanted to welcome all of our Regenstrief Institute folks, but also we have special guests today. So we have guests from Dartmouth and Harvard visiting us, and we'll hear more about that in a moment. But really wanted to welcome everyone to Regenstrief Institute and just say a couple words about Regenstrief Institute for our guests. So we are a nonprofit research institute. We are a support organization to Indiana University, specifically the School of Medicine. And we conduct research in many different areas, but largely our goal is really to transform health systems and communities. We focus on how do we use data for impact. So we have a number of different centers. We have our Center for Health Services Research, our Center for Aging, and we have the Center for Biomedical Informatics, and two programs. Our Regenstrief Data Services does a lot with data delivery as well as national linkage honest broker work, among many other things, and our Health Data Standards Unit. So we do a lot in this space, but we're really focused on our mission on impact. How can we impact our communities both locally through discovery, as well as nationally? How can we serve as a model nationally? So I'm delighted to introduce Susan Hickman, the director for our IU Center for Aging Research at Regenstrief, who will introduce our distinguished speaker for today. Thanks and welcome.
Thanks, Rachel, and I echo her welcome. We're so delighted to have all of our guests here today, as well as our Regenstrief Institute community and friends from campus. It is really a great pleasure to be able to introduce our speaker today. We have, for the last several years, had a list of nationally known, prominent investigators who we have hoped to bring here for our Sam Regenstrief Distinguished Lecturer Series. And Dr. Vincent Mor has been on that list since the outset, and we had this beautiful confluence of events that happened with the meeting of the Dartmouth PO1 and the advisory group accompanying that, and we were able to put all of that together and bring Dr. Mor here today. I will say I have a very long introduction for Dr. Mor, and I'll do a little of it, and then I'm going to turn the mic over to him because he has a lot of great stuff to share with us today. But Dr. Mor is the Florence Pirce Grant Professor of Community Health in the Brown University School of Public Health and a senior health scientist in the Health Services Research Service at the Providence Veterans Affairs Medical Center in Rhode Island. Dr. Mor has been the PI of over 40 NIH-funded grants that focus on the use of health services and the outcomes for frail and chronically ill persons. He has published over 450 peer-reviewed articles and has won numerous awards, including a Distinguished Investigator Award from Academy Health, and has been elected to the National Academy of Engineering, Science, and Medicine. I think as a researcher and an investigator who has focused on long-term care, one of the things which I feel most indebted to him is his role in the creation of the congressionally mandated minimum data set for nursing home residents, which is an assessment of nursing home residents that happens on an annual and quarterly basis and creates this large pooled data source that can be really valuable in research processes at multiple levels. He is also the architect of an integrated Medicare claims and clinical assessment database for policy analysis, pharmacoepidemiology, and population outcome measurement. And this data resource is funded by the NIA program project grant, Changing Long-Term Care in America, which leverages the MDS. I think the only other thing I'll say, many of our investigators have been involved in the Impact Collaboratory, which is Pragmatic Clinical Trials U54 for pragmatic trials and dementia care. And Dr. Mor is one of the MPIs of that project as well. And it's been a really incredible experience in terms of moving the field forward and how we take care of older adults with dementia and their caregivers. So I'm really delighted to introduce our special guest, Dr. Vincent Mor, and I'll turn the floor over to him.
Thank you very much. So I'm really very honored to be here today. I was in the late 80s, early 90s. I was appointed to the Secretary's Committee for Vital and Health Statistics, and at the time, Clem McDonald, who some of you probably know, was a member of that committee along with Don Detmer, who was the chair, who at the time was provost of University of Virginia, and they're like giants in the field of health informatics. And I had no idea that that's what I was doing, was health informatics, but I guess that's what I'm doing, and I'll be describing to you what I've been up to in this process. So I'm going to talk to you about the Long-Term Care Data Cooperative, its origins, structure, and functioning. And in order to put it into some background, I have to give you some history about how it came to be and in the policy environment. Okay, so just acknowledgements. There are lots of people, lots of grants, et cetera, that I was involved with. And the work that I'll be presenting is sort of really many people have been involved in this. I no longer have any conflicts of interest whatsoever, so except I'm an NIH investigator. What I'd like to do is go over sort of some background on research in U.S. nursing homes, then talk briefly about COVID and how it changed everything, gave us some interesting ideas, particularly how we could actually take information from nursing homes and make it a policy environment and to link it up with other kinds of data and take the EMR and to go one step beyond this minimum data set, multiple steps beyond it. Then I'll talk about the history of building the cooperative, then the governance structure, and then how to use it and where it stands and what it can do for you and how it can be used. And I'll end with a sort of a vision of the future. For those of you who are really old, you'll remember that there was a time that the National Institute on Aging funded things called the teaching nursing home. So what I'll give you at the end, I'll leave you with a vision of what a virtual teaching nursing home might be. So begin with the Institute of Medicine, now the NASM, convened a committee to explore nursing home quality effectiveness. At the time I was at Brown, I'd been there for some time, and Sid Katz, who was the chair of this committee, came to Brown while he was chair of the committee. So we were very much involved in the formulation of the ideas and the recommendations that came from the Institute of Medicine Committee on Nursing Home Quality. It was one of the most amazing committees because it actually yielded recommendations that were directly translated into law into OBRA 1987. We don't ever actually have real laws. We only have budget reconciliation acts. So the minimum data set was then created. It was one of the recommendations to have a formulation and an assessment, because at the time, nursing homes basically didn't do assessments. Some did, but there weren't very many, and there was lots of pushback from the best nursing homes saying, oh no, we don't want you to tell us how to do this. But most everybody in the nursing home world had no clue how to do an assessment. So we took the principles of geriatric assessment and tried to embed it into an ongoing structure. It was then we mandated as part of Medicare certification for all Medicare and Medicaid certification for all nursing homes in the country. And as Susan suggested, it had to be done on admission, and then every quarter thereafter. Medicare later used it as a payment scheme and added its own frequency of assessments that went with it. And then I was part of the team that actually helped create it. We had a big contract through CMS as part of that process. And then very shortly thereafter, some states began to computerize it, and I was the first person to actually take the state's MDS data and match it up with Medicare claims before there was a ResDAC and before there was any of those things that was now available. So once you've built this kind of infrastructure, this is the lecture I begin my course with my students on how to work with Medicare data. You can begin linking those assessments and the histories that they provide and the much more detailed clinical and functional information about the patients to Medicare claims to give you a complete history. You can concatenate the records to create what we call a residential history file, which basically says, I know where everyone is on every single day. I have to interpolate a little bit, but basically that's the case. And if you have Part B claims, you know every doctor visit in that process. And you get this incredible picture of the history of that person. And you can link provider characteristics to the patient in a individual or a network structure, depending how you want to do that. You can then aggregate the patient characteristics up to the level of the provider to characterize the provider in some very important way regarding who they do and do not serve relative to the environment in which they're in, like what county or what zip code or what groups. And then you can create population aggregates at various levels. So all of a sudden, from this population level, in fact, it's numerator data, it's essentially numerator data, you can create this incredible denominator about the population that has the movement through the nursing home environment. And where there are data, there's science and publications. And so this just shows you the number of publications in Medline where there's nursing home in it. It starts at 300 and something per year in 1990, and by 2020 there were 620 per year, and it just keeps going up. So the data make it possible to do research. This here. Oops. Okay. So we began by having data on pharmacoepi, because we initially began with information on patients' drugs matched to their Medicare, matched to their MDS, their minimum data set, and then of course matched to Medicare claims and the mortality outcome. And so we began to look for the first time at the effect of atypical antipsychotics, which at the early, if you remember that far back, that was quite popular early on, and people thought they were the wonder drugs. And we began to look for identifying real consequences associated with that. We also described, pain for cancer patients, and had never been described in this context in the nursing home population. We could also then just simply describe who was in these nursing homes. You could do it for people at the end of life. You could do it in terms of the end-of-life transitions, going from nursing home to hospital and back and forth and back and forth. And those ideas of the rehospitalization, those came from this early work that was done. And of course, you could then look for other kinds of transitions. And if you knew where the nursing homes were and who was residing in those nursing homes, you could find, oh, it so happens that nursing homes with high minority concentrations located in communities with high minority concentrations were much more likely to close. And those things were possible. And we'll do policy analysis from bed hold at the state level, which is a requirement that that the state says, we will pay the nursing home some amount of money to keep that bed open while the patient is in the hospital, and what that does for the hospitalization rate underlying that. We could look at, average selection into Medicare, and then we could look at exit from Medicare Advantage for people who are the highest need, highest cost patients. And this kind of work continues unabated by our group at Brown. What we initially thought of this as a wonderful data structure for doing observational research, policy research, pharmacoepi research, and it never really dawned on us until we had this brilliant idea. Oh, I bet we could use these data for doing real embedded, real world data pragmatic trials. So we started off with high dose influenza vaccine versus standard dose influenza vaccine, randomly assigned 400 nursing homes to get the high dose and 400 nursing homes to get the standard dose, and waited for the data to come to look for the outcomes. And Susan Mitchell, my partner in crime on Impact, and I did the same thing with a much more complicated intervention, a video. Now, that one didn't work, but it's really hard to get interventions to work when you're trying to implement something in a nursing home context. But but the data is what was used. So this paradigm of using these data as the basis for doing pragmatic trials became sort of the basis for the embedded pragmatic trial work that we're doing now, funded by an NIA. We also just created an aggregate use file basically for public use at the provider level, 15, 16,000 nursing homes. We could characterize them, and those data are now available for use by anybody. Just download them on LTC Focus. There's a provider level, a county level, and a state level, and we have data back through 2000. So it's now 20 plus years of data that are made available through this kind of mechanism that otherwise no one would have known. And I still review lots of manuscripts, and the number of manuscripts that I come and say, oh, and we use this and this and this, oh, and also LTC Focus. They don't even know where it came from, but it's there. So COVID then changed everything. So 4 or 5 months after Susan Mitchell and I got this impact grant, we started working with folks here at IU, and all of a sudden, everything stopped. We'd already given some money away to pilots and demonstration projects, and everything stopped. I had a program project at the time, and so I was able to immediately get a supplement to work with one of the firms that had been part of the cluster randomized trial, and we promised to help them solve their problems using our data analysts. And so literally, I got nightly downloads of full EMR data from this company, 200 plus nursing homes across the country. And we figured out some way to get the data up and running so that we could have weekly meetings with their leadership to actually try to help them figure out how to do cohorting, how to identify, which buildings were in trouble or which buildings were not in trouble, to merge that data together with the local data that was being published by Hopkins and others about what the county level infection rates were literally coming out every week. And when you put that together, you begin to realize that, oh, it's the county that affects the likelihood of an attack, a COVID attack in the nursing home, and not is it the nursing home high quality or low quality, but it's what else is going on in that community. And those were really important lessons in that process. And so we were fortunate. We got a bunch of stuff out related to vaccination, the New England Journal and JAMA, internal medicine, about 30-day mortality. And those were all things that we did in conjunction with our colleagues in the nursing home setting. And in many respects, it was like the most satisfying research I'd ever done, because it was real and had immediate impact on how a firm was working and how patients' lives were being led. My graduate students had no idea how unusual an experience that they were having in this process. So these daily EMR downloads gave us this notion that, we could actually do this with other places. And so in a short time, we realized that there was information that we had in these data that were just unavailable otherwise. We had daily vital signs. We had daily blood sugar levels. We had daily, 3 times a day temperatures. And of course, we had not just the prescription, but we also had whether the orders were actually being administered. And so that gave us a lot of insight. And, oops, wrong. Okay. Right, so then we got a bunch of other firms that sort of wanted to get on the bandwagon. We couldn't do the nightly download. That was just too much to have all these other firms. Even though we were working with the same EMR vendor, it was, as everyone in the building knows, you've seen one EMR installation of the same vendor, you've seen one EMR installation, because it's hard to bring all those together. But we did work with other companies, and we've got 12 nursing home companies, about 1,000 facilities, all using a particular kind, point-click care. We had a signed data use agreement with all of them, and we began doing analysis and generating this information for them. It was initially focused on SARS-CoV-2 and had additional funding from something called Radix Up, which for diagnostic work, I don't know, it was a big NIH initiative that we got money for. But it actually became the basis for doing another pragmatic trial. So this is just a map of where all of the nursing homes are. Since all of these guys signed DUAs, I can actually show you where they are, but in our long-term care data co-op, not everyone wants to be known as saying they're participating, so I'll only show you a state map, but this is where these firms are. And then we did a trial. We got four of the firms to identify a bunch of their reasonably performing facilities. We got involved with them. We randomly allocated them to an experimental control condition, and the experimental condition was to improve vaccination rates of both the patients as well as the staff. And we had to do this. We got the DSMB, we got the IRB approval. First, we had to get permission from NIH to allow us to do something different with the money that had been identified for testing, but actually have it focus on vaccination. So we got that permission early in December. We got the DSMB like 3 days before the first rollout of the vaccinations on December 18th, and we got the IRB and rolled things out literally on January 3rd. And so we were pushing out all kinds of different materials to the experimental nursing homes. And then by the end of March, all the vaccinations had been done, both staff and patients. And within 2 months, we had all of the data in hand and all completely analyzed and ready for publication. I've never done a study as fast. I've never worked as hard in my entire life. And it was just remarkable. Now, again, there were many, many factors associated with who got vaccinated, who didn't get vaccinated. Our intervention was not one of them, but at least we knew we could actually do it in the process. So it did give us a notion that perhaps if we actually move properly, we can get this done and institutionalize it. And so we decided to design a governance structure and a data infrastructure for now and for the future, and not just for our use, but for others to use as sort of a resource. So we expanded the data cooperative to include many more facilities, to include nursing homes that had different EMRs, and to have at least monthly updates if that was necessary. And we wanted to include everything that was in the EMR, including modules that only some of the providers would have, like the vital signs and other kinds of things. So we also wanted, of course, link these data to Medicare claims and to MA encounter records, ultimately, so that people could work with these data. And we felt that this would create a dynamic monitoring for changes in individual patients' conditions, ability to, figure out how new medicines were being diffused across the country in these kinds of settings, to find a pool of nursing homes that would be willing to participate in trials, and sort of would be the next generation. And so that was the vision behind this whole idea, and that's what I'll spend the rest of my time with you. So the mission is to improve the quality of care within nursing home facilities by compiling the most comprehensive data on post-acute and long-term care residents nationwide, and to translate these data into accessible and actionable information designed to help clinicians, managers, and policymakers improve care. So I guess for those of you who are Regenstrief types, this is probably a mission that is not unlike what you're familiar with about how these systems have to work. Of course, we had to do it our own way, so we're smart enough to actually come and visit you and borrow in advance, but that's so much for that. The approved uses are population health analytics to support. That's basically to give feedback back to the providers who are members, to do public health surveillance, to use the data for observational comparative effectiveness research of all different types, comparative effectiveness, and to do clinical research studies, including randomized trials. It's a provider-based cooperative. It's managed by the American Healthcare Association. They're sort of like I guess the accepted or respected or trusted intermediary in that sense. It's funded by NIA under a grant, our impact grant to Brown University. It's a provider organizations. Each of these provider organizations have a business associates agreement with ACA, and they give them the data, and then ACA contracts with a company which is the data management partner. And then researchers apply to the data cooperative to use the data, and they separately apply to NIA through something called linkage to use the NIA the claims data link under linkage. Okay, so this is just a little bit. We have about 2,900 signed up now. We figure it's about close to where we're likely to be, maybe 3,500. Who knows exactly? We have 3 different vendors. The vendor data goes to the EHR data is all curated in a common data model, et cetera. The researchers apply to ACA and a committee in that process. And separately, the data are linked to Medicare claims, and a separate application process go through there. So that's the structure in place. We've got just 2,900 facilities signed up. It sort of goes up and down a little bit. We've now ingested data from about 1,800 nursing homes so the most important thing, and some of you might appreciate this in ways that I didn't as not an informatics real person, is that the vendors wanted to make very sure that when their clients, the providers or the companies who run the provider companies, send them authorization that, oh yes, you can share our data to ACA in this particular format, that the name on that authorization is exactly the same name with no commas or otherwise, or dashes or otherwise, as the one on their contract with the vendor. And so I can't tell you how many times they got the names wrong, because somebody who signed the contract for the vendor agreement was not the same person who signed the contract, even though it was a different CEO. And so we've had to go through this fairly elaborate process of redocumenting every one of these. And that's why 1,800 is not 2,900. And the NIA has been beating us around the head for not having ingesting as much data. But right now it's about 1.1 million residents in the data. 72,000 residents have 3 years of data complete, because remember, this includes both the long stay as well as the post-acute patients. There's lots of information about the providers who are actually coded into the data, because they're the ones who fill things out. They have a provider, they have a number of one sort, they can be identifiable, and lots and lots of detailed assessments. Here's where they stand. So Indiana is well represented, because matrix care is dominant. Some of the West Coast will be dominant on the groups that as the ones that are being signed up now. Sex distribution, as you can imagine, more women than men, but this is how we are. So for those of you who are interested in younger people, there's a hefty chunk of people who are under 54 who are there, on whom we have detailed information. It's the race distribution. We have about 13% African American in that funny distribution of facilities that we have right now, and that will probably be going up a little bit as the rest of the participants become obvious. So what's the value of these EHR data relative to just having claims or the minimum data set? Because the minimum data set, lots of information on function, on symptoms, and so on and so forth. Well, there are, first, there is a census file. So you actually know if that person is in the building that day. We don't have to interpolate anymore on our residential history file. So we know exactly, because we have a from and to, and literally they have an everyday census because they need to know who's there for billing purposes, because most billing is by day. Vital signs, we have BP, heart rate, respiration, temperature, pain, literally every day. There's blood glucose, height and weight every day. And for temperature, it's sometimes 3 times a day. It's just remarkable how much data is there. And on the immunization records, in contrast to the MDS, which has just the basic influenza and pneumococcal, they have all the vaccinations, including the exact date when they occurred. So you are able to do some finer things with these data. Do I have? Okay. The lab data. For those of you who are familiar with Epic and otherwise, some installations have things, some tests are there, some tests. The same is true here. So anybody working with these data have to clearly look and say, does this provider have any of this kind of data? And then if so, what proportion of the people in the building have this kind of data? And you probably have to know something. Am I looking for a hemoglobin, A1C, or am I looking for a CBC? CBC is done all the time. So if there are no CBCs, then you say they don't have anything like that. They have no lab. But there's nobody out there saying, oh, this building has none of this. You have to go and find it yourself. Because in fact, many of the providers don't actually know what installation of their EMR that they have. It's there. They just have to work with it. The orders data, we have non-medication standing orders for PT, range of motion, walking, bathing, advanced directives. Those are all in the order set. Okay, so there's text. So we're working with smart people who know about natural language processing and those kinds of things. And at some point, we'll start running this through our own AI vendors, because we can't give this to anyone to run. So we have to figure out some way to download it. That's for people smarter than me. There's clinical data. We have, so the lab data depends on the use of the centralized lab. As I mentioned, many nursing homes get this, the BP, temp, et cetera, on a regular basis. Blood glucose is there. So we have people who care about diabetes. They're so excited they can't see straight because you get really, really detailed information. So the medication administration, so we know when it's administered, not just what was prescribed. And since these are legal records, they, somebody's license is at risk if they are fooling around with the data. Where did this go here? Okay, here we go. It's a little slow on this. The vaccines, 1.2 million influenza, COVID vaccines and influenza vaccines. It's just huge numbers of people are getting these vaccines. And so you know exactly when they're happening. And you can begin to look for adverse events or otherwise, et cetera, in this population, as opposed to just looking at the claims, where you have much more information than you can do that with. Okay, here we go. The clinical events, so the lab data, we have about 67 million lab results. So there's a lot of lab data. And examples of blood glucose, the CBCs and the hemoglobin A1C, and there are lots of COVID tests in there. The vitals are there, literally, I think that number is lower now. We have almost a million vital sign estimates. And so we can look at temperature literally every day, looking at how someone's temperature rises in advance of their becoming positive for COVID, et cetera. The medications are just massive, and the medications obviously include non-prescription drugs. So if you know whether someone's getting acetaminophen And you don't otherwise know that from the Part D claims. And the medication orders, well, speaking of acetaminophen, this is exactly what the structure is, how you look at it with the data, and this is the data that's in every single order and/or every single, and each order is then linked to an administration through a common number. And yeah, so this is the medication administration record. And so the data are at the administration level. So you just aggregate up, and so it's just a vast amount of information. There's a core data model. We have the EMR 1, 2, and 3. There's, the transform data is then put into sort of a data lake, as it were. It's put through a common data model structure. Where it's not OMOP, but it has some similarities to it. And then it's finally pulled into the core data model. This is the large cylinder there is the source for the standard data cut, which we're making available to most people. They have certain variables that will or will not be given to them. And it's available for CDC public health monitoring or researchers. And each researcher then has their own space to work in these places. There are about, I think, 8 researchers now working independently in that environment, which is kind of amazing to me. I put all this together. There are people really using the data. Okay, here we go. And the data are supplied by the IT have been harmonized and organized into these basic concepts. So there's the episode stay, there's the observation, which includes the labs, et cetera. There's the conditions, which are the diagnoses and otherwise, et cetera. And there are lots and lots of assessments, the MDS assessments that are necessary. Plus, most of these places are also doing daily bedside assessments of function and cognition by the aide. And so you actually have them every day. And the MDS nurse or the assessment person, when they put together a formal MDS at the quarterly level, they're just taking averages of those and they interpolate for what the purposes are. So we now have a technical user guide, which goes through all of this stuff. You can get online, it's available. We're creating a data on data in each of these areas so that people can use it, and that'll be sort of aggregated at the provider level. It'll be all blinded. You won't know which provider is which, but it could help in doing some preliminary power calculations, how much data is on each type from each provider of each type, so that you can actually say, oh, here's my question. Might this be possible to do without necessarily having to go through the whole application process? So back to the approved data uses. This is the population health, public health surveillance, observational, otherwise. So yes. So we generate provider reports. This first report, it's kind of 3 different pictures, one report that goes to a provider. This one's about hospitalizations. I don't really, it's on how many hospitalizations are on each day of the week. I think it's a count of the number of actual hospitalizations of people that are residents and that have, how many people, et cetera, that's given directly to the provider through a secure portal. This is the benefit of signing up, as it were, because it's free to the providers, obviously. And then we're working with CDC on a whole series of issues. They're particularly interested in influenza, of course. And so, as most of you know, influenza is not something that's diagnosed very often. In fact, it's rarely diagnosed. So we had some smart kids who are, PharmDs and other kinds of people who work with infectious disease people. They said, oh, well, let's look for Tamiflu. And Tamiflu is actually then a sign prophylactically of it being used, and it's likely there for the whole group. It's not necessarily a perfect individual diagnosis, but it's a good example at the level of the facility. And so, so you can actually begin to say, how much is this building being affected, and are they behaving prophylactically, or are there real symptoms? And so we're still in the process of working with CDC, but they seem to be quite pleased about how these data can be used for this kind of purposes. And there will be lots of other infectious disease and other quality issues that they'll look at. We're still sort of trying to figure out how much a provider has to opt in to participate with some of the CDC collection or analysis versus how much they can do that just everyone has to do. So we're still working on that. But this gives you a sense of the diagnoses are in the blue and the Tamiflu orders are in the reds. So boom, they're happening. And when we looked at this is a particular provider. When we look at this in relation to where that provider is, there's CDC data from the influenza rates in that community that seems to correspond with to the spike that occurs. So there's the nice sources of validation. So for observational comparative effectiveness research or clinical research, that's what most of the people in the room will be caring about. And so approved uses or observational comparative effectiveness research would be generally cross-sectional or longitudinal analyses comparing patients who were or were not exposed to a particular treatment, a drug, a test, what have you. If you happen to know that these 52 buildings all do X, then you could compare people in those 52 buildings to people who don't have it, or were exposed to different treatments and we're still discovering what's in the treatment arm on the orders side. And then on the clinical research study, disease would be incidence and prevalence, as well as phase 3 or phase 4 clinical trials, studies that evaluate the interventions, and studies that collectively that collect additional research. So we're now working with some folks who have these really inexpensive but incredibly accurate monitors that you put on for heart monitoring or blood glucose monitoring or so on and so forth. And gives you a general complete stream of data. How you integrate those data with, presumably with having consent with the buildings that are participating, that we're still working on the details about the best way to do that. So this was approved, one study looking at incident hypoglycemia in patients with and without sliding scale insulin. The effectiveness of staff dementia education was a trial being done, and adverse events following Paxlovid treatment was another study being done. Not approved were adherence to a diabetic clinical practice guidelines, because that gets too close to the nervous point of you're identifying me as a bad provider, and trends in antipsychotic prescribing in for-profit versus not-for-profit nursing homes. You can use a different data set for that. In fact, you're better off doing policy work, actually using the Medicare claims linked to MDS, because that's the entire population. So this is for clinical research, and I feel pretty comfortable about that purpose. I am quite certain over time, the nursing homes will want to have answers to some of these questions, but we'll let that happen in time, because there are lots of really good comparative effectiveness for questions. So I sort of mentioned that. It says, why not quality performance? It's because you can get the data from other sources, and you don't want to get your partners unhappy. This is a matter of trust, and it's really important to keep that trust in place. The application process, the researcher submits specific aims, et cetera, and the long-term care data cooperative does a preliminary review. We'll write a letter of support if you're going after submission for that, but ultimately your proposal has to go through. The review committee will convene following a comment period from various providers, so that it is sort of open and democratic in that respect. There aren't many outside comments, but the review committee has good representation. The review committee of 3 members of the data co-op, from Brown, Aka, and the data partner, 1 from the advisory board. I think that's probably Susan, or going to be, and then 6 people from the industry, from participants. And the evaluation criteria is it meets the criteria, it merits scientific priority, and the proposal includes sufficient detail. And We do have a publication review process, and just like CMS, you can't extract or download data lower than 11 people per cell or those kinds of things, which is, standard de-identification stuff. We do work with people on getting a plain language abstract because providers are going to be reviewing these things. It's a good exercise for people to write something that a reviewer, so that this is not for your NIH crowd. This is for the real crowd of real people. And it's a structured abstract, that has material in it. And we've been working, and Dave Gifford, who's my partner in this at ACA, has been very active in pulling this, in helping people put this. So there is no cost for a standard data set. So you have a standard data set, it will be put available. NIA supports this activity, so you can, as a researcher, work with these data, and on you go. Standard access basically includes, secure cloud computing, access to the coded data elements, not, uncoded information, and up to 5 concurrent users, and tech support up to 8 to 12 hours, et cetera. So we're still working on the tech support stuff, but we're trying to be moderately user-friendly. It's difficult. So the next step. There's a separate application to use the merged data with Medicare claims. The standard data set goes to work as being submitted and stored at a place at basically Acumen, which is a firm that is contracted by NIA under linkage. And the match rate comes in at about 98% for the Medicare beneficiary population. So it's quite high. So the ultimate size, we think, is going to be about 3,500 facilities. We'll see, give or take some, representing about 200 organizations. We expect that about 500 to 1,000 may participate in clinical trials on a sort of a regular basis. Of these, and if anybody is working with a group of nursing homes that is not already part, they can join for free, and that means your access is going to be there for your use in the future. For doing a clinical trial or doing research that requires something more than a standard cut, you work with ACA and the data managers to figure out what the cost is likely to be for whatever it is you're going to need, whether it's help in recruitment, help in integrating new data, or even, some fancy NLP kind of work. So if you have research coordinators, can gain patient proxy consent, you can actually do a phase 3 trial. It's more complicated, but it's not impossible to do. Ultimately, we expect about 250 facilities to have really complete EMR data, lab data, which they go through a standard national lab, so you get actually quantitative lab information, where in some sense, it enables us to look at really carefully what this population is over time, as well as what actually happens to them during a post-acute care session. We're also in discussions with the largest EMR rehabilitation vendor in the country to see whether they too might be interested in participating, at least for some of these facilities. As the vision really is having something like a sort of a virtual teaching nursing home. And it's going to help us understand aging physiology, how to develop and implement interventions, because, developing interventions that the nursing homes are willing to actually implement and that can be then implemented by the on-site staff in terms of reorganizing work is really hard, really hard. But having partners do that, it makes it at least possible so that it can become then a standard so that other providers can learn how to do that. And this is the basis potentially for a consortium that would actually then do some learning from itself in that process for people, more engaged, et cetera. And then, once the infrastructure is in place, it can be adapted to all kinds of organizational developments that occur within that nursing home on an ongoing basis. And it actually is a model for other, I call them boutique or not mainstream, i.e. hospital or primary care providers who could be part of a system like this or adjunct to a system like this. And how to do that under proper circumstances is possible with a common data structure. And this just gives you sort of a picture of, so you imagine all US nursing homes are out there, and then you have the long-term care data co-op, and we can actually make exact determinations of how close this circle is, this circle is to that group, and then the small group in between as well, because that's what the juncture is. And on the patient side, it has the same thing, but you have the difference between, you can figure out the post-acute and separate from the long stay. And that gives you then the real meat to be able to look at these two. So I will stop there. Thank you very much for your time. I appreciate it. There's even a few moments for questions. Yes. I can repeat the question, or you can hop up to the mic.
Good number.
I just want to thank you so much for this presentation. I learned a lot. Karen Fortuna, Assistant Professor of Psychiatry at the Geisel School of Medicine at Dartmouth. This was an amazing presentation, and I want to thank you because my father had a rare, serious illness where he was in a nursing home in and out a lot. And I recognized as a family member the quality of the care that he received really varied between these nursing homes. And so from this work that you have done has really transformed like the research landscape, but also like as a person, speaking on behalf of my late father and as a family member, thank you so much for this work. It's incredibly important.
Thank you.
I also want to add as well, I remember one time I spoke with my dad and I asked him, I'm like, why did you get sick? I was like 10 years old. He didn't tell me it was genes or anything biological with him. He said it was the stress of having to work 100 hours a week for the job that he's entrepreneur. And so I wonder with the White House playbook on social determinants of health, how potentially that can actually change the data infrastructure to actually integrate social determinants of health and maybe change the landscape of research again.
So I don't know if the landscape of research can address the issue of excess stress for entrepreneurs, but it certainly can. I mean, we know a lot about the zip code around which every single nursing home is located. And you can got the zip code, the 2-digit zip code, the 3-digit, whatever it is you want it, the market. And we know a huge amount about that in terms of, and there are lots of measures that come from community survey and census, et cetera, that can characterize the environment. And we also know exactly where someone lived before they entered the nursing home because we know what their zip code and even 9-digit zip was. And so that transfer ability, there's a lot of power in that. We can do that without these clinical data. We can do that right now, and Amber and her team at Dartmouth are doing a lot of that work. My group at Brown has done a lot of that. What's the advantage here is that you actually get to look at some of the clinical information, at the vital signs, at the exact order, so you can look at replications, at variation in adherence to orders, et cetera. And things that we can't even imagine. As I tell my students, even with Medicare claims, which seem now quite, rudimentary, no. The only limitation is your imagination. There are so many things you can ask. And these data are even more intricate. And again, it's the limitation is your imagination.
Thank you.
Somebody's coming up.
Hi, John Kansky, Indiana Health Information Exchange. Apologies if you already know this, but Clem McDonald and others at the Institute in the 90s created a very similar data cooperative that today is statewide in Indiana, not focused on long-term care data, but focused on clinical and claims data. And ironically, SNF data is one of the gaps that we have yet to fill, and we're working on that.
I'm sure your colleagues here can talk the rest of the Indiana group into saying, oh, we'll ship our data.
Yeah, already talked to them now. Okay. I have actually a question of economics about the data cooperative that you covered. Two-part question is, and I'm sorry if you covered it, how are the costs of the data collaborative covered today? And is that the plan in the long term? And do the EHR vendors require that they be compensated for their work in contributing the data?
Yeah, so the answer is right now, NIA is paying for this. It's, you know, around $3 million a year between the inputs of various sources. About $1.5 million for the data grappler, data manager, and then a bunch of money for the individual vendors for generating, just, you know, basically transferring their data monthly.
Thank you.
Vince, amazing work, and I'm just building on what they say. You created the engine that will change an actual patient care outside of policy. I think we've been playing policy based for thousands. I mean, not thousands here, but quite a lot, and has not really translated to what happened in COVID and everything else. And this data core you have, it's going to the clinical care.
I'm hoping.
So therefore, it's become like a treasure in sustainability and learning from lesson learned from the experience that happened in Regenstrief. The health information exchange, literally the same concept. It's local instead of national. And we have created self-sustainability with iHigh, but it might not be a bad idea to really create an advisory group with the iHigh team for the self-sustainability. Otherwise, it might happen to you what happened to us with Gopher and EMR. You know, Epic came over and took over, and I don't think they did.
So right now we're anticipating 5 more years of funding. Sometimes during that 5 years, some longer term arrangement fiscally has to be put into place. You know, we're just started. We're just, you know, just putting it together. So I have a plane to catch. So I want to thank you all very much. I'm just delighted to be here. Honored.